Welcome to the Singapore Cancer Society's Women's Gynaecological Cancer Webinar 2024. I'm Annie, your host for today. This webinar is in partnership with AstraZeneca, Roche, and supported by National Cancer Centre Singapore, Singapore General Hospital, and KK Women's and Children's Hospital. Before we begin, let's start with a quick introduction about Singapore Cancer Society. Established in 1964, Singapore Cancer Society is a self-funded social service agency which provides patient care services to patients in need through its cancer treatment subsidies, welfare, rehabilitation support programs, and hospice care. In addition, SCS also provides free cancer screening services and promotes cancer awareness and prevention through its public education and community outreach program. In today's webinar, we would share with you all about cervical, ovarian, and uterine cancer, and covering an interesting topic. Does your family genetics play a part in cancer occurrences? We would also be having a survivor sharing and a Q&A session. If you have any question and you're on Zoom, please submit them by clicking the center icon at the bottom of the screen. And if you're on Facebook, you can also share it in the comment section. We shall answer as many questions as possible. We will also be sharing important information and useful links in the chat box for your references. You can also rewatch this webinar on Singapore Cancer Society's Facebook page after the event. Without further ado, let's welcome our first speaker, Dr. Joella Ang, Consultant, Department of Obstetrics and Gynaecology, Singapore General Hospital. She would be sharing about 3 most common gynecological cancers. Over to you, Dr. Ang.
Thank you so much, Annie, for the kind introduction. Let me just share my slides. Okay. So, good morning, everyone. Thanks for joining us on a bright and sunny Saturday. My name is Joella, and I'll be talking to you about gynae cancers and what you need to know. Just a brief introduction about myself. I'm a consultant obstetrician and gynecologist from the Singapore General Hospital. And my subspecialty is gynae oncology. I'm also a council member of the OGSS as well as the NCCS of Singapore. So this is the agenda for today. We'll be talking about how common cancer is, the different types of gynae cancers, and also a summary about the 3 different types of the most common gynae cancers. So cancer is the #1 killer in Singapore, and every day, 37 people are diagnosed with cancer, and unfortunately, 16 of them actually die of cancer. 1 in 4 may develop cancer in their lifetime, and 1 in 3 deaths are actually caused by cancer. So this is a very important thing that we need to talk about. In Singapore women, the top 10 cancers are as follows. And you can see, number 4, number 5, and number 10 are actually from the gynecological system. So number 4 would be uterine cancer. The top 5 would be ovarian and fallopian tube. And the top 10th is actually the cervical cancer. So what are the gynecological cancers? Well, the gynae system, as you can see on the picture over there, we talk about the uterus, which is the womb, the ovaries and the tubes, as well as the cervix, which is at the top of the vagina. And the most common ones are the ovarian, uterine, as well as cervical cancer. So in terms of endometrial cancer, what's the endometrium to begin with? So the endometrium is actually the inner lining of the womb. And this lining actually changes as we go through our menstrual cycle. So it sheds off during menses, and during the different phases of our menstrual cycle, it thickens because of estrogen, and it changes after ovulation because of the hormone called progesterone. And to simplify things, when there is a drop in the progesterone, that's when actually menses happens. So what is endometrial cancer? This is actually the abnormal growth of cells from the inner lining of the womb, or the endometrium. It's the 4th most common cancer in Singapore women. And the numbers we are seeing is actually increasing through the years because it's mainly related to lifestyle changes, obesity, as well as diabetes, which we know is very common in Singapore. Are you at risk? Now, women who are above the age of 40 years old are at higher risk of endometrial cancer. Women that are obese or have diabetes have a higher risk of endometrial cancer as well. In addition, women who are never been pregnant, who've had their first period before the age of 12 years old, or menopause after 55 years old are at higher risk of endometrial cancer. And this is because of the risk of the unopposed action of estrogen. So because of this risk of unopposed estrogen, patients that have infrequent or irregular periods less than 4 times a year are at a higher risk. So women with polycystic ovarian syndrome, because they have cycles that are very irregular, they have a lot more estrogen without the progesterone protection. They are at higher risk of endometrial cancer. In addition, if you have breast cancer and you are on tamoxifen, this puts you at a higher risk of things like endometrial polyps or endometrial cancer. And if you are taking hormone replacement therapy, for example, just estrogen alone, that also increases the risk of endometrial cancer. If you have a personal history or a family history of breast and ovarian cancer, uterine cancer, or Lynch syndrome, which also includes the things like colorectal cancer, you are at higher risk of womb cancer. And Dr. Zhang will be talking to you a bit more about genetics later on in the second talk. So what are some of the symptoms that you might have if you have endometrial cancer? The most common thing would be abnormal bleeding, because like we mentioned, the endometrium is related to the menstrual cycle. And if you had abnormal menses, for example, if there's spotting in between the cycles or bleeding between the periods, changes in the heaviness or the length of the periods, or even bleeding after menopause, these are all symptoms that could indicate endometrial cancer. So menopause, as most of you know, is when there's 12 months or 1 whole year of no periods, and any bleeding after that is considered abnormal. And I would ask you to actually advise you to seek a doctor's for advice. Some additional symptoms of endometrial cancer includes bloody or watery discharge, abdominal or pelvic pain or pressures. If you had painful intercourse or you found that yourself losing weight without explanation, or a tummy, abdominal, or pelvic lump, these all could also point to endometrial cancer. Could we be screened for it? Well, unfortunately, for endometrial cancer, there are no standard guidelines for routine screening. But because endometrial cancer tends to present with abnormal bleeding, I would advise you to see a doctor if you have symptoms of abnormal bleeding. A lot of times, endometrial cancers present very early in the stage, for example, stage 1. And this is because women come to see us when they have abnormal bleeding. So yes, I would advise you to track your cycles, monitor how your periods are, and seek advice and professional healthcare professional if there was any changes to that. How do we diagnose endometrial cancer? So when a patient comes to see me, and if they've got risk factors, they have abnormal bleeding, I would first actually take a history. I'll do an examination, and we might do some scans. For example, an ultrasound scan looking at the lining of the womb and its thickness. We will also do a biopsy. So this can actually be done either in the clinic itself with something called an endometrial sampling, where we take cells from the lining of the womb, and then we send it to the lab to look under the microscope. The alternative is to actually go through a surgical procedure called a hysteroscopy, dilatation, and curettage. And this is usually done under general anesthesia, where we actually put in a camera into the womb and actually look at the lining of the womb for any other growths or polyps or fibroids, or if the lining looks just thickened and abnormal. Thereafter, we actually scratch the lining of the womb and we send that to the lab for testing. Majority of time after diagnosis of cancer, we would do staging scans, including MRIs of the pelvis or CT of the chest as well as the abdomen. And then we would also discuss about treatment. In terms of treatment, if, for example, a patient is of early stage, a surgery to remove the womb, the tubes, and the ovaries, as well as possibly needing to remove the lymph nodes, can actually remove that source of cancer. Majority of the time, we do this as a keyhole surgery if it's appropriate and it's suitable. This could also be done as a robotic, or we might do it as an open surgery or a big cut in the tummy. Thereafter, If required, patients may also need to go for radiotherapy or chemotherapy. So now knowing all this, is there anything that we can do to actually prevent this? I would advise you to control your weight with diet and exercise, as we know that obesity increases the risk of endometrial cancer. In addition, regulating your periods, having regular periods is very important. And if, for example, you had polycystic ovarian syndrome, or if you had irregular periods, you can actually seek the advice from a gynecologist to actually regulate your cycles to reduce the risk of endometrial cancer. Also, I heavily emphasize this about monitoring your periods through ways like tracking apps, and see a doctor if there was anything abnormal. Okay, so now we're done with endometrial cancer. We're going to move on to the second cancer we're going to talk about today. And this is ovarian cancer. Now, ovarian cancer is actually known as the silent killer because it's quite difficult to detect it early, as a lot of our patients actually don't have symptoms. So it's the 5th most common cancer in Singaporean women. It can affect one or both ovaries. And in terms of gynae cancers, it is actually the most deadly. The reason why it's called the silent killer is because they don't tend to have very obvious symptoms. Symptoms are very, very non-specific, and a lot of our patients tend to ignore them. And then they might come to see us when it's late in the disease, stage 3 or stage 4. So there are different types of ovarian cancer. I'm just going to quickly go through these before we mainly talk about the epithelial ones. Now, in the ovary, there are many different cells that can happen, that can turn into cancer. Now, the surface of the ovary is called the epithelium, and that is one area where epithelial tumors can actually arise from. And this is actually the most common area where cancer of the ovary comes from. In the ovary, there's also cells that turn into eggs thereafter, and these cells can also mutate and cause cancer. These are usually in either the older patients or the very young patients, and they are called germ cell tumors. There are also cells that are in between these cells, and these are called stromal cells that can mutate, become stromal cell tumors, and they usually produce hormones like estrogen and progesterone. Now, I'm mainly going to focus on the epithelial cancers because that's the most common ones. So in terms of the risk factors, we know that age also plays a role. We know women who are older or they are postmenopausal have an increased risk of ovarian cancer. Genetic mutations, for example, BRCA, which I'm sure Dr. Zhang will talk about, also put you at a higher risk of ovarian cancer. For example, if you are BRCA1, the chance of a lifetime risk of ovarian cancer may be as high as 40%, BRCA2 up to even 25%. In addition, if you have a family history of breast, ovarian, and colorectal cancer, there may be another type of genetic condition that also increases the risk of ovarian cancer. Having a condition called endometriosis, well, having endometriosis per se isn't actually a cancer condition, but having a large endometriotic cyst does increase the risk of endometrioid or clear cell ovarian cancers. Not having any pregnancies and lack of breastfeeding can also put you at a higher risk. And also with endometrial cancer, having a high-fat diet or being obese also has an increased risk of ovarian cancer. Like I mentioned before, the symptoms that our patients present with ovarian cancer are usually very non-specific. So for example, they might complain of things like bloatedness, abdominal pain, back pain, changes in their toilet habits, like going to the toilet more often or less, having issues with their bowels, feeling full faster, losing their appetite or losing weight. These are all symptoms that could be related to ovarian cancer. We want to beat ovarian cancer by recognizing the signs. So B for bloating, E for eating difficulties and feeling full, A for abdominal or pelvic pain, and T is for toilet changes. So do remember this very nice little mnemonic. What about screening? So I do have a lot of patients come to ask me, Doctor, ovarian cancer is so scary. It's something that's a silent killer. Then can we screen for it? Well, unfortunately, if you are considered low risk without any risk factors and what's called general population, there are currently no standard guidelines for routine screening of ovarian cancer. The reason is because studies have been done that show that even if you had regular ultrasounds or CA125 blood tests, that hasn't been shown to reduce the risk of actually reduce the mortality from ovarian cancer. patients come to see me with a raised blood cancer marker like CA125. The thing is, for CA125, it's not the best tumor marker available. I mean, the reason is because these tumor markers are non-specific. It can be normal in early cancers, and it can be high in cases that are not cancer. For example, things like fibroids or even having a period can actually cause the CA125 to be raised. So it's not the most useful. What I would suggest is if you have any symptoms or bloatedness, abdominal pain, or changes in the toilet habits, see a doctor for examination as well as for a checkup. If you are above the age of 50 years old and you have new IBS symptoms, for example, with abnormal bowel habits, bloated, constipation, diarrhea, see a doctor rather than dismiss it as just IBS. If you have a family history of ovarian, breast, or even colorectal cancer, you may want to do genetic testing, as there are ways that we can actually reduce your risk. How do we diagnose ovarian cancer? If a patient comes to see me with symptoms, as like I mentioned, I would take a history, I'll do an examination, and I would also do some imaging. This might include an ultrasound scan looking at the ovaries and the cysts. This also could include things like CT scans or even MRIs. We do tests, including tumor markers, just to give an indication about how likely it is to be cancer. We might even want to do some biopsies or taking out some fluid, but these are usually at advanced stages to diagnose. In early stages, if it was a suspicious cyst, we usually don't do that because of the risk of spilling if it was really cancer. And if the cancer cells spill into the tummy, that could also actually increase the stage of cancer. Treatment of ovarian cancer is usually through surgery with chemotherapy, depending on its stage, and a combination of this too. So what can you do to actually prevent ovarian cancer? Well, we know that having a regular cycle is also very important. And women actually sometimes take the birth control pills to actually reduce the risk of ovarian cancer. Now, if this is something that's suitable for you, you can actually discuss with the gynecologist about that, because even taking, say, for about a year can actually reduce the risk of ovarian cancer by about 20%. Taking it for 5 years may reduce by about 50%. Of course, there are some risks of taking the birth control pills, which you could discuss with your doctor. Some patients, after completion of their family, may choose to remove their tubes, and we find that this actually can reduce the risk of ovarian cancer, as now it's been thought that sometimes the cancer actually starts from the end of the tubes, and it might actually seed onto the ovary as its precursor. If you had high-risk genetic mutations like BRCA1 and 2, you can actually have surgery to remove the tubes and the ovaries, and that can actually reduce the chances of ovarian cancer by even up to 90%. Being pregnant or breastfeeding can also reduce the chances of ovarian cancer. Okay, I understand I'm a bit short of time, so I'm going to move on to the third cancer. The third cancer we're going to be talking about today will be cervical cancer. So what is the cervix? The cervix is actually considered the neck of the womb, and it's located at the top of the vagina. Now, cervical cancer is actually very different from the other two cancers. It is actually the most common female cancer in developing countries, but in Singapore, it's actually the 10th most common cancer in women. The mean age is about 51 years old, peaking at about 45 to 60 years old. And the majority of cervical cancer is actually linked to an infection by a high-risk human papillomavirus, or HPV. Now, HPV is very, very common. It's a very common infection affecting more than 80% of women, people in their lifetime. There are more than 200 different types of HPV. And most of us, when we get the infection, more than 90% of us will be able to clear the infection like a common flu. 10% of us, unfortunately, this infection stays with us for a bit longer. And if you have a persistent infection with a high-risk type of HPV, this can lead to precancer and cancer. So the types that are higher risk includes type 16 and 18 that causes 70% of cancer worldwide, and a group of 12 different others. Compared to someone who's never been infected with HPV, HPV 16 and 18 increases the risk of cancer significantly. HPV infection can also cause problems in men, including things like penile cancer, anal cancer, and low-risk kinds can cause things like genital warts. So the good thing about cervical cancer is that there's a very long time from a normal cell to become cancer. It takes at least 10 to 20 years for cells to change, which means there's a very good time span that we can actually pick this thing up. So we can actually diagnose patients even before the cells change to cancer and we can treat them. Risk factors of cervical cancer includes things like smoking, having multiple sexual partners, having a history of STDs, having HPV infections, or a weakened immune system that you can't clear an infection. Unfortunately, OC pills has also been found to increase the risk of cervical cancer. Some of the symptoms of cervical cancer, including abnormal bleeding. So if you remember the chart, the picture, the cervix is at the top of the vagina. So a lot of times, if patients have cervical cancer, they may come with bleeding after intercourse. They may also have irregular spotting or bleeding, and also may have bleeding after menopause. Bloody watery discharge, abdominal pain or pressures, or painful sex are the symptoms of cervical cancer. Can it be picked up earlier? As I was alluding to earlier, absolutely. And this is through cervical cancer screening. So pap smears and HPVs can actually pick these precancerous cells up even before it turns to cancer. And if we can detect it, we can actually treat it before it turns cancer. Unfortunately, for precancer, sometimes you may not have any symptoms, like I mentioned before. And the only thing that we might find is actually a normal pap smear or a HPV test. So this is how we actually perform the HPV or pap smear. So when you see a doctor or a nurse, what we do is we actually look at the cervix, we use a brush and we take some of the cells and some of the samples from that area and we send it to the lab for testing. The good news is that because of our screening, it actually has decreased in numbers as well as in incidence. So in the 1970s in Singapore, this was actually the fourth most common, and now it has dropped to number 10. Also, with HPV vaccination and protection against the high-risk viruses, this can also has shown to actually decrease the amount of cervical cancer we get in Singapore. And although, yes, we're doing quite well in terms of that, we can also do better. So in 2018, the WHO actually had a global call to action against cervical cancer. And we're trying to aim for 70% of women actually screened. Unfortunately, right now, we're only hitting about 48%. And we want to get 90% of our girls and women actually vaccinated against the virus. Now, in terms of cervical cancer screening in Singapore, we start at 25 years old if you've ever had intercourse. From 25 to 29, we do pap smears, and that's every 3 years. As HPV infections are very common in this age, and because when we're young, our immune system is very good, we're more likely to clear the infection. After 30 years old, we do the HPV test looking for the high-risk viruses, and if it's normal, we can do it every 5 years. It is more effective, and it tests for these high-risk strains like I mentioned before. If you had an abnormal pap smear or a HPV test, you might be recommended either for repeat testing or to see a doctor in the colposcopy clinic. Now, colposcopy basically means a more detailed check of the cervix under magnification. We use various medical stains to bring up changes of the cervix, including acidic acid as well as iodine. And if there are any areas that are suspicious of precancer, we can do a biopsy to confirm. And if we find it, well, it depends on how severe the precancer is. If it's just mild changes, sometimes we just observe because it can actually regress back to normal. But if it's a higher risk that has a chance it could turn to cancer, we might be able to just perform a minor surgery, either through local anesthetic or general anesthesia, to remove just that area of affected cervix. If unfortunately we didn't pick it up in time and it has turned to cancer, the ways that we treat cancer really depends on the stage and the age of the patient, but maybe a combination of either surgery versus things like radiotherapy or chemotherapy. Can you prevent this? Yes, absolutely. If you are smoking, I would encourage you to stop smoking. You can also limit the partners that you have, use condoms, as this can somehow can also reduce the chances of getting multiple types of HPV. Going for the HPV vaccination can also protect one from the HPV virus and reduce the risk of cervical cancer. So there was a very big study that was published in 2018 that vaccination can even reduce by 99% the risk of cancer if it was given before anyone was exposed to the virus. There are 3 different vaccines that are available in Singapore: the bivalent, the quadrivalent, and the monovalent. And these cover various strains as indicated here. For Cervix as well as Gardasil, those are Medisafe claimable and included in the adult and childhood vaccination schedule since 2010. The amount of Medisafe that you can claim has also been increased, and this is limited to women, girls, and women aged 9 to 26 years old. In 2019, we started actually vaccinating our girls in school, and this was actually a free opt-in HPV vaccine using the Cervix vaccine. So, in conclusion, women's cancer is something that's very common. I really believe that prevention is better than cure. And going for screening, for example, your HPV and your pap smears can detect early disease and can prevent cancer. Ways that we can prevent includes things like stopping smoking, controlling your weight through diet and exercise, eating less processed food, less red meat, more fruits, vegetables, and fiber, and limiting alcohol can actually help reduce the risk of cancer. Attend your screening, go for your vaccination is also very important. And also to monitor for your symptoms of your menses and see a doctor if necessary. Thank you so much for your time. I will take the questions later on during our Q&A.
Next up, we have Dr. Zhang Zewen, consultant, Division of Medical Oncology at National Cancer Centre, Singapore. He will be sharing about hereditary ovarian and uterine cancer. Over to you, Dr. Zhang.
Okay, thanks, Annie. Good morning, everyone. My name is Zewen. I'm one of the medical oncologists from National Cancer Centre, Singapore. I'm very happy to be here today to share with you about hereditary ovarian and uterus cancer, also known as endometrial cancer. So when I use the word hereditary, I'm referring to cancers that develop as a result of a certain genetic mutation that's passed down from generation to generation. And this is the focus of my talk today. So when we talk about hereditary cancer, we often need to mention about genes. I will talk about the relationship between cancer and genetics, some of the genetic testing that we offer at NCCS. Then moving on, I will discuss specifics about ovarian cancer, uterine cancer, and such of the syndromes related to hereditary syndrome. So all of us have DNAs in our body, and the DNAs contains genes. So what are genes? Genes are, imagine they are like codes, instructions to help our body function normally. Our genes also determine things like our health, our height, our hair color, skin color, eyes color. The genes are inheritable, and each of us have 2 sets of genes inherited from our father and our mother. And of course, this set of genes can also pass down to the next generation. When a gene is functioning normally, our body is able to read the codes on the gene and produces protein that help us in our day-to-day functions, such as our metabolism. However, if there are any errors in the coding in the gene, then it cannot function normally. And because of that, the gene can produce abnormal protein, resulting in abnormal function. Sometimes in more serious cases, no proteins are made, and our health, we can't function normally, and it can actually lead to quite serious disease. So when we have a faulty gene, it's usually because these are inherited since birth. When we talk about mutation in cancer, often there are 2 kinds of mutation. On the top is what we call tumor or somatic mutations. This is not what we'll be discussing today. Instead, we'll be talking about germline mutations, which is what you see in the bottom. Germline mutations refer to mutation that is already seen when the embryo develops in a pregnant woman, and the embryo already contains a mutation that is inherited from either of the parents. Okay, and this mutation is always in the body, and the person grew up with it, and the mutation can be passed down to the next generation. So some of this mutation can then, because of abnormal function, can increase the risk of what we call hereditary cancer. Yeah, and that is what we'll be talking today. The one above that you see are what we call tumor mutation, and this cannot be passed down. These are mutations that occurs in the tumor or cancer. So when somebody is diagnosed with cancer, often the question in their mind is why? What's the cause? Most of the time, I would say 70 to 75% of the time, the causes of cancer are what we call sporadic. Sporadic means that these risk factors develop over time due to things like aging. When you're aging, your DNA don't replicate in such a normal fashion, increasing your risk for cancer. That could also be other lifestyle and environmental factor. Smoking, alcohol can also increase the risk for cancer. But the focus of our talk today is on the hereditary component. It means the causes due to inheriting from generation to generation. And this usually constitutes about 5 to 10% of the causes of cancer. May I draw your attention to the right diagram? So when I see a patient with cancer, I like to take a very detailed family history. And if the family history is suggestive of something that runs in the family, for example, the grandmother has breast cancer, the uncle has colon cancer, and another cousin has two cancers, breast and ovarian, then my alarm bell will start ringing, whether the individual in front of me actually have something that runs in the family that's inherited. Yeah. On the other hand, if you look at the left, if I were to take a history and there are no strong family history, then perhaps this is less suggestive of a hereditary cancer. So as mentioned before, at NCCS, we have a cancer genetic service. So this is where we offer genetic testing. Genetic testing is very simple, very straightforward. It's like a one-time blood test. Imagine if you go to the poly to have your cholesterol or diabetes checked, it's taking one small tube. From this small tube, we are able to then analyze the gene to look for any mutations that might increase your risk for cancer. For some reason, if this test cannot be done or we think it's not suitable, well, there are other ways we can do it, either by saliva or taking a piece of skin tissue for evaluation. And before we do that, over at our cancer genetic service, we offer a very detailed genetic counseling, helping the individual in front of us to understand and adapt to the medical, psychological, and familial implications of hereditary condition. We'll spend quality time with you, explaining the reason, how we do it, why we should do it, and what happens after we do it. And I've heard patients with cancer asking me, look, I already have cancer. Why is there a need to check for genetic mutation? Well, I will tell them that, number one, if I were to find a genetic mutation, I get an answer. I can give you an answer why you developed the cancer. Number two, if you do have a genetic mutation, you potentially have increased risk of developing other types of cancer. And I can then guide the patient what you should do next. You should go for a certain special form of screening, okay, to pick up the risk of other cancer that hasn't developed. And the purpose of doing that is that we can then pick up cancer in the pre-cancerous stage or very early stage, and something meaningful can be done. In certain cases, in certain genetic conditions, which I will elaborate later, there are now already very targeted, very specific drugs that can target the genetic mutation. Okay, that can help to increase the effectiveness of treating cancer. And last but not least, I also tell my patients, genetic testing is not just, in the end, it's not also about yourself, because if I were to pick up a genetic mutation, I can then offer to your family members testing. And imagine if your family member is very healthy now, and they do carry a mutation, I can then put them on very effective screening measures so that I can pick up cancer in early stage or even in the stage 0 setting. Of course, there are much more in terms of counseling than what I just mentioned above, but these are mainly the points I'd like to highlight. What are the benefits of doing such testing? We'll move on to specific. So before me, Dr. Ang, she has talked about ovarian cancer. She talked about various potential risk factors, but I'd like to focus on the hereditary component. So I think by now most of us are no stranger to this chart. This can be found on the Singapore Cancer Society website, listing the 10 most common cancers in males and females. In females, the most common is still breast, but you can appreciate that in terms of gynae cancer, uterus and ovarian, they are listed number 4 and number 5 respectively. So we know that ovarians are part of the female reproductive system, and they produce the eggs and help to regulate the female sex hormone. Generally, the risk factor of ovarian cancer in the normal population is about 1 to 2%. However, in an individual who already had diagnosed with ovarian cancer, there's a 20 to 25% chance the cause is because of the hereditary component. So the signs and symptoms which Dr. Ang has mentioned can include what you see here: abdomen pain, frequent urinating, bleeding between menses, loss of appetite, change in bowel habits. But we also do have to take note that these symptoms are not specific. So I do not want you to go back today and start becoming paranoid. The moment you have any tummy pain, you go and rush to see a doctor. The thing is that in many cancer symptoms, the symptoms are persistent, they are recurrent, and they usually become worse with time. So if you have any of these symptoms such as abdominal pain, and usually that's because of gastritis or some infection, it should go away. But if it doesn't go away after 1 or 2 weeks, or become worse, or you start to develop more symptoms, that's where you really need to see a doctor. And then they can do further scans or further blood tests for you. This is an age-related risk of ovarian cancer. This kind of graph is actually quite common in almost all other cancers. You see an increased incidence with aging. And that's, like I mentioned before, aging is one of the important causes of cancer. But for ovarian cancer, it sort of dropped after age 75 because of changes in the female hormones. So when we talk about hereditary ovarian cancer, we need to discuss about the hereditary breast and ovarian cancer, HBOC. HBOC is a syndrome. A syndrome refers to a manifestation of potentially developing several types of cancer. Now, HBOC is usually because of a mutation in 2 genes called BRCA1, BRCA2, BRCA1, BRCA2. Now, all of us here, we all have BRCA1 and BRCA2, and these are good genes. These are what we call tumor suppressor genes. So when they function normally, they usually help to repair your DNA. They keep your DNA growth in check, making sure that your DNA, your cells do not grow too fast or in an uncontrolled manner. However, if our BRCA1 and BRCA2 are not functioning normally, that means they are mutated. And this mutation is because we inherit them from either father or mother. Okay, if they cannot function normally, you can imagine our DNA cells start to grow very fast. They might become ugly, and then that's how they eventually become cancer. So if you have a BRCA1 or BRCA2 mutation, there's a higher chance your cells can go to become cancer compared to another individual with a normal functioning BRCA1 and BRCA2. So being a BRCA1 or BRCA2 mutation carrier does increase your risk of developing HBOC syndrome. But there are also some individuals with this mutation that may not develop cancer. Okay, they might be the luckier individual. However, because of the higher risk of developing cancer, we always counsel what should we do in the next step. These are the cancers that are associated with HBOC. So male and female breast cancer. So yes, even male can develop breast cancer because males also have breast tissue. Ovarian cancer in the female, prostate cancer in males, pancreatic cancer in both gender, and even skin cancer. There are some differences between BRCA1 and BRCA2. Overall, in BRCA1 mutation, there's a higher risk of developing cancer. But in BRCA2, we see that there's a slightly higher risk of pancreatic cancer. So after you get diagnosed with a BRCA1 or BRCA2 mutation, what can we do next? Yes, there are things that we will then counsel you about. So when it comes to the breast, we'll offer imaging scans starting at an earlier age of 25 instead of the Singapore recommendation of age 40. We'll start much earlier. And we might even offer a more detailed scan called the MRI breast, which we don't do routinely in the normal population. And the reason for MRI breast is that it's a more detailed scan so that we can pick up cancer earlier. Sometimes your doctor will discuss with you risk reduction surgery. That means even before cancer develops, we'll discuss with you whether you want to just take out the breast in a preventive fashion. The same goes for the ovaries. Okay. Of course, these are very individual decision, and we can always discuss about it and will not say force that you have to do it. So one example is that the Hollywood celebrity Angelina Jolie, she has a BRCA mutation inherited from her mother, and she went for risk reduction surgery of her breast and ovaries even before cancer developed. Next, we'll move on to hereditary uterus cancer. So uterus of the womb is part of the female reproductive system, the organ where the fetus goes and receives nutrients from mommy. The lining of the uterus is called the endometrium, which is why sometimes you hear the term uterus or endometrial cancer using synonym in a similar fashion. They refer to the same thing. On a population level, if there's no mutation, population level is about 2 to 3%, slightly higher than ovarian, but about 10% of endometrial cancer is hereditary. Other risk factors have been mentioned by Dr. Ang, usually because of lifestyle. Things like diabetes, being overweight, and not having children. Again, the signs and symptoms of endometrial cancer are listed here. Again, these are not specific. However, if you have any of this, such as bleeding from the vagina that's persistent, recurrent, continuous after 1 or 2 weeks, you should definitely see a doctor for further checks, okay, which include further scans or further blood tests. Age-related risk. Remember, I mentioned that for most cancer, you usually see an uptrend, increased age, increased risk, and then it slowly drop off after 65 to 75, mainly because of changes in the female hormones. So, a couple of slides ago, I discussed about HPOC syndrome, where there's an increased risk of breast ovarian cancer. Now we talk about Lynch syndrome, which is another syndrome that has certain cancer associated with it. So Lynch syndrome is also due to inherited mutation, okay? But now the mutation happened in our DNA mismatch repair gene. And two of the most common well-known genes are MLH1 and MSH2. Again, these genes are good genes. All of us have it. They normally protect us from getting certain cancers. But a mutation in them can prevent them from working properly, can increase the risk of DNA error, and from there, increase risk of developing cancer. Lynch syndrome is passed down in an autosomal dominant fashion. This means that if mommy or daddy has the mutation, there's a 50% chance that the offspring can get it. HPOC, due to BRCA mutation, is also inherited in an autosomal dominant fashion. The Lynch syndrome associated cancer are listed here, quite a few. Colon cancer, uterus cancer, stomach, ovarian, bladder, the small bowel, also sometimes known as the small intestine, prostate in the males, and pancreas. So when we pick up a mutation that we think can lead to Lynch syndrome, we have strategies and guidelines that we will then implement to help to either prevent cancer or pick up cancer in a very early stage. And these strategies include, number one, colonoscopy that start from an earlier age, compared to the age of 50, which is recommended for Singaporeans. We'll start earlier age between 25 to 30. We'll consider scans of the womb and even consider removing the womb. In addition to colonoscopy, which is checking the colon, we'll also ask the individual with the mutation carrier to go for a pop scope to look at the stomach. This is to look for stomach cancer. For ovarian cancer, we'll discuss about risk reduction surgery. Many times we will discuss this after childbearing age. And for bladder cancer, we'll be checking the urine for any abnormal cells. So you can appreciate that when we find a mutation in the gene that we think can lead to a certain syndrome, we have good strategies to deal with the possible cancers that can arise. I'd like to draw your attention to colon cancer. Although it's not the gist of our talk today, there are some evidence to suggest that taking aspirin can reduce the risk of colon cancer in the setting of Lynch syndrome where there's a genetic mutation. Again, this decision is to be made on an individual case-by-case basis because aspirin can have side effects also. Remember me talking about effective cancer treatment because of underlying genetic mutation? Well, this is an example. So nowadays, I'm sure a few of you have heard about this therapy called immunotherapy. Immunotherapy is not chemotherapy, but it is also a type of cancer treatment therapy. And what it does is that it stimulates your immune system to fight the cancer cells. So one of this drug is called pembrolizumab. It has been FDA and also HSA approved to be used for patients to fight recurrent uterus cancer. So if yourself or you know someone with a recurrent uterus cancer, you should always be screened for whether you have a genetic mutation that causes Lynch syndrome, because if you have, then you have more options to fight the cancer. So I'm coming to an end of my slide. I would just like to reiterate the Cancer Genetic Service, where we have a specialized counseling session to help to identify and manage patients and their families at higher risk in developing cancer. We'll discuss with you the strategies that we think is most appropriate for you. And by doing that, we hope to manage, reduce, or even prevent cancer. You can see that my summary slide is very similar to Dr. Ang. We always believe that prevention is better than cure, and knowledge is power, which is why we are here today to share the knowledge with you today. Thank you very much, and I'm happy to take any questions.
Thank you, Dr. Zhang, for the insightful sharing. Now, let us welcome Amaliah, a brave mother of two who discovered her cancer during early screening. Let's hear from her how she navigated this unprecedented event in her life. Hi, Amaliah. Good to see you.
Hi, good morning. Hi, morning,
Good
everyone.
morning.
Yeah.
So, Amaliah, today I know that you're going to share your story. I can start with asking you some questions, perhaps. When were you first diagnosed with your cancer, and how did you react?
I was diagnosed 5 years ago, 2019, and I was only 36 years old. Yeah, it was just through a normal routine check of pap smear.
So, were you very shocked when you heard the diagnosis?
Yes, I was. I was very, very, very shocked because there was no symptoms. I was perfectly fine. I was living quite a healthy lifestyle. I didn't expect when the doctor diagnosed that it was actually cancer. It was quite a shocking moment.
So just now you mentioned about there's no symptoms and you just accidentally picked it up during the screening. After the diagnosis, how was your treatment journey like? Did you go through any different treatments?
Mm, that's a problem because I was diagnosed with cervical cancer, and the only treatment that doctor could actually provide me was actually hysterectomy. I was also I have no idea what is hysterectomy all about, clueless. So when doctor told me that is the only treatment I could do, it was also another shocking part from my side. Mm,
So you had a surgery, and
yeah.
after that, did you have also other treatments as well?
For mine, hysterectomy was the only treatment I could do. So it was actually I did removal of my womb.
Mm.
So they told, but my ovaries are still there. So no other treatment required. I didn't need to go to any radio or chemotherapy, which was very great. I'm glad I didn't had to go to that stage. Mm.
And did your family and friends support you through this journey?
Yes, I got so much support from my family members because it was quite shocking for everyone. They didn't expect that. I was diagnosed with such cancer, and was very young also. Mm.
Yeah. So how did they practically support you? For example, did they try to help you out in your day-to-day activities, and did they support you emotionally?
Emotionally, yes, because it was quite a very painful moment because there's nothing else to do except hysterectomy. So doctor also told me that I can't waste any more time. I can't wait any longer. So after talking to both my parents all, and they say that please listen to the doctor and do what is best, or what doctor said is if it's hysterectomy, that's the only thing you can do. And I already have 2 kids, so it's fine. Yeah, and they told me to just proceed with all whatever the doctors has recommended. Mm.
I'm so grateful that you're in remission now after the treatment. In
Yeah.
your cancer journey, what is the one thing that you would like others to take away?
Actually, cancer is not the end of everything. And the very most important is if you can detect early, it will save your life. You know, I always this my own doctor always told me that I was very lucky. She told me that what I did early detection saved my entire life. Yeah, so it's thankful. So everyone should do early screening. All the girls in school, I mean, in our generation, it's good that they are introducing all the vaccine available. Yeah, prevention, like what Dr. Zhang said, prevention is better than cure. Yeah.
Thank you so much, Amaliah, for your sincere sharing. And we
Yeah.
wish you all the best,
Okay.
healthy and happy. And we
Yeah.
hope Amaliah's story has encouraged you all to do early screening. Now we'll open the floor for Q&A. Please do send us your questions on a Q&A box. And I already received some questions before we open the session. So perhaps I can start with Dr. Zhang first. So thank you so much for your insightful hereditary cancer sharing. And I think this is really new information for a lot of people. A question that we received is that, does having breast cancer increase my risk of other gynecological cancer? You've already covered it partly. Perhaps you can also recap a little bit for the person who asked this question.
Okay, thanks Annie for the question. Breast cancer itself, in the general population, does not necessarily increase your risk for uterus cancer. However, there are certain specific situations where it might increase. Number one, when you have breast cancer, your doctor might ask you to take certain hormone pills to reduce your risk of breast cancer coming back. And what some of these pills might potentially increase your risk of developing uterus cancer. So that context is because that's related to the medication that you are taking. So that's scenario number one, where it can increase your risk. Yeah, not a direct effect from the breast cancer. And the next scenario, yes, if you have a genetic mutation that can cause both breast uterus cancer, and if you are found to have the breast cancer and the genetic mutation, then you can potentially have an increased risk of uterus cancer. So some of the genetic condition that can cause both breast and uterus cancer is Lynch syndrome, where the genetic mutation happens in MLH1, MSH2. Yeah. So I hope that answers the question.
And Dr. Zhang, a follow-up question is that, do you think if we include CA125 marker in health check, is it good enough to screen for ovarian cancer?
So Dr. Ang has mentioned that just now in the slide. As oncologists, we do not recommend screening that includes CA125. So CA125, it's a cancer, it's what they call a cancer marker, but CA125 itself is not sensitive or specific. What do we mean by that? So imagine somebody has no symptoms, they go for a health screening, and they find that their CA125 is on the slightly high side. Studies have shown that most of such individual, in the end, they actually have no cancer. But because the CA125 is slightly raised, then that person goes for many scans, many tests, and some of these tests can be what we call invasive. That means might actually cause harm to the body. Yeah, and then in the end, it turns out that everything is negative. Yeah, so the person has gone for unnecessary checks, spend the unnecessary money, and only to find that everything is negative. So because of that, CA125 is not something that's very helpful. Yeah, so I do not routinely suggest the screening of CA125. But if a person has already done it, then we can then explain to them what the result potentially mean. And on the other hand, if the CA125 is negative, it doesn't mean there's no cancer also. Yeah, so we don't want an individual to be so fixated on the number, and then maybe other things that are more important. Yeah.
Yeah, thank you, Dr. Zhang. In
No
fact, this
problem.
situation happened to my friend as well. She had a raised CA125 marker and she went to the specialist and went through all the check, eventually discovering that she's completely okay. So
Good for
for
her.
all those, yes, very
Yep.
grateful for her. And
Yeah.
if you're also facing this situation, let's be assured by what Dr. Zhang has mentioned.
Yeah.
Okay, another question for you is that
Mm.
if a sibling has ovarian cancer in her 50s, would that put other siblings in a higher risk category?
So 50 is a very arbitrary number. Usually when a person is diagnosed cancer after 50, the chance that it can be related to a genetic mutation is not so high. But nowadays, guidelines are being revised. When we see a family member, multiple member in fact with cancers that is diagnosed more than 50, we still have to think of a hereditary component because some of the genetic mutation, the cancer may manifest at a later age. Yeah. So if you're not sure, if you have someone that have cancer in the family that diagnosed more than 15, and then not just one, maybe one or two, definitely you should still see a doctor and then talk about whether you need to go for genetic testing. Yeah.
Dr. Zhang, one last question for you,
Sure.
also related to hereditary cancer. One of our audience has mentioned that she has recently found that she carries a BRCA2 gene. What is the impact? What is the impact that it has on her son? And should that person be worried about having another child?
Okay, so there are many layers to this question. So if you indeed do have a BRCA2 mutation, whoever that did the test for you should already have give you the appropriate strategy that things that you should go for, such as going for breast screening, discussing about risk reduction surgery like removal of the breast tissue and ovarian. Yeah. If you have a BRCA2 mutation being found, then yes, what we'll do is we'll offer predictive testing. That means testing of your family members, okay, to look for whether they carry BRCA2. So if the audience will ask the question, the son has a son who is more than 21 years old, we would recommend for the son to go for testing of the BRCA2. Because remember in my slide, I mentioned that males can also get breast cancer. And BRCA2 don't just cause breast cancer, it can also cause prostate cancer. Yeah. The second part of the question, whether you should still have a child, definitely you can still have a child. Having a genetic mutation does not stop you from having a child. Having a genetic mutation in the setting of BRCA2 means that your child has a 50% chance of inheriting it. But nowadays, under the IVF guideline in Singapore, BRCA is one of the conditions where if you are found to have a mutation, you can then go for IVF procedure to select the embryo that doesn't carry the BRCA mutation. Yeah, that's one of the indication where you can go for IVF under government policy. Yeah, so if you do indeed have a BRCA2 mutation, you can ask for referral to see the IVF specialist in our institution, I think KK site, then they can counsel you accordingly how the process can be done. Yeah.
Yeah. Thank you, Dr. Zhang.
No problem.
Before we move on to the questions for Dr. Ang, perhaps I can ask Amaliah a question. This is a personal question about her and her mom. How do I get my mom to go for screening? She said she's feeling fine and doesn't need any. So from your experience, how would you encourage the mom to go for screening?
For mom, I think everybody has a very strange feeling for this test because it's pap smear. Everyone, not mom, even my friends will say, no, I would not want to go. Why? What if something pops out, when I go for this screening? Then I will just share it's better you detect now rather than you in a later stage where there's nothing you can do. And just encourage them, follow them, and tell them it's nothing. It's just a test, which can save your life.
Thank you, Amaliah. So I also have some questions for Dr. Ang. The first question is, does having an irregular period attribute to a higher chance of getting gynecological cancer?
Yes. So, for example, if your cycles are very irregular and you have less than 4 cycles in a year, that increases the risk of endometrial cancer. If you mean by irregular periods, you mean by having very heavy menses or the cycles are too long, that could also be a symptom of endometrial cancer. I would advise you to see a gynecologist to actually go through your cycles and how you're experiencing them, to actually see if you are at risk of any of these cancers that we've mentioned today.
And there's a question about hysterectomy. So there's an audience mentioned that she had a hysterectomy years ago. Does it mean that she will not get cervical cancer? Does she still need to go for regular pap smear?
So that's a very good question. Now, to actually answer this, we need to know what type of hysterectomy she went for. Did she have the entire womb removed, including the cervix? And what was the report of the cervix? So usually after an operation, we send it to the lab, and the lab actually looks at the cervix under greater detail. If there was no evidence of cancer or precancer of the cervix, and if she's had the entire womb and cervix removed, she may not need to go for any further pap smears as there's no more cervix left. However, if there was any abnormalities found or detected during that operation, she may still need to go for screening thereafter.
So it really depends case by case.
That's right. That's right.
Yes. Okay. And for people after menopause, are fibroids or ovarian cysts a concern, and does it need to be regularly checked?
That's also a very good question. So I do have patients coming to see me for that very reason. Now, we know that fibroids are very common, and more than 50-60% of people would have them. And the majority of the time, fibroids are non-cancerous. Only less than 1% of them are cancerous. Generally, after menopause, these fibroids should shrink. It might take a while, may take years for it to happen. But we see the fibroid is growing at an alarming rate. That's something that's not normal, which might need a regular check or even a surgery. But if, for example, if you had stable fibroids and after your menopause, it's still stable, we may not need to actually repeat the scans again. Now, ovarian cysts after menopause. So after menopause, we expect the ovaries to actually be, quiet in a sense. And if there are actually large ovaries or large ovarian cysts after menopause, that also is a risk that it could also be something not so good, like even cancer. So very important to monitor yourself in terms of symptoms and see a doctor when you have persistent bloating, abdominal pain, or changes in your cycles.
Dr. Ang, you also mentioned that fibroids are very, very common among women. How do we differentiate the discomfort is due to just benign fibroids or whether or not it's something more dangerous?
So that's also a very good question. I did see in the note someone in the Q&A, someone that had an appendicectomy, or they thought it was appendix and it was actually a fibroid. So it's very difficult to differentiate between types because pain is unfortunately in the lower pelvis region. And in that area, pain could be related to the gynae organs. It could also be related to the bowels, like the appendix or the colon. It may also be related to the bladder. So things like bladder symptoms or urinary symptoms and infection can also present with pain. So if you do have pain, see a doctor. We can actually do an assessment and check to see where this pain is actually coming from. Sometimes I may screen the urine for infection. I might also send my patients to see our colorectal colleagues to do an assessment as well, to really differentiate the pain.
Okay, so a reminder is if you're in doubt, remember to see your doctor. Okay, another question is related to sexual activities. If one has not been sexually active since the last screening for HPV, which is 5 years ago, does one have to go for further screening in the future?
So if the patient has ever had intercourse, no matter how long ago it is, I would still recommend you to go for the screening either by a pap smear or HPV, depending on your age. And even if your last pap smear or HPV was a few years ago and you've never had no new partners, I would still advise you to go for the checks. If you've never had intercourse before, you don't actually need to go for cervical cancer screening.
Thank you. And we do have another question related to menopause. This lady started menopause at 52, but after 6 months, the flow came back and it is heavy. Is this a sign that she needs to be worried?
That's a good question too. So as I spoke during my talk, menopause is actually 1 whole year or 12 months of no period. If you had a cycle and it stopped for 6 months and it came back again, it may be related to what we call a perimenopause. So the cycles, they go further apart before it completely stops for a year. So that could be what you're going through. It could be the perimenopause. But because that cycle was abnormal, because it was heavier, if it was prolonged, you should still see a doctor anyway, because this abnormal bleeding, even though it may be related to perimenopause, could also still be a symptom of endometrial cancer.
Okay, thank you, Dr. Ang. We have a series of questions flowing in, also like during the session. So I'll pick this question, which is, okay, if I had hysterectomy done, am I free from endometrial cancer?
Okay, so yes, if you had had your entire womb removed with the cervix, yes, you shouldn't get endometrial cancer anymore because there's no more endometrium. But if your ovaries are still there, there is always that chance of ovarian cancer in the future. Yeah. I saw some questions I thought I would just address as it's coming along. Okay, so the difference between pap smears and HPV screening. So now pap smears, basically, the way that we do both pap smear and HPV is the same. We put a plastic device into the vagina, we look for the cervix, and we brush that area. Now, for pap smears, what it looks for is actually abnormal cells. So it tells us currently, do you have a precancer or cancer, or if it's normal. But the HPV test, instead of looking at the cells, we look for the virus instead. Now, we know the virus, if it's present, doesn't mean that it's cancer, but it tells us about the risk that you might develop it in the future. So instead of looking for the effect, we look for the cause.
Okay, another question for Amaliah.
Yes.
So
Hi.
Amaliah, can you share about your lifestyle? And do you think, did you suspect there's any impact on your lifestyle, on your risk of having cancer?
Or lifestyle after or before?
Before.
Or before? Before I was feeling perfectly fine. So I was doing jogging, running, eating very well. So when I was diagnosed, like it was very shocking because I thought I was okay, but actually no. Yeah.
Understand.
Mm.
Okay, next question. Perhaps it's for Dr. Zhang. For cervical cancer in older women, until what age women needs to go for pap smear?
I'll actually leave this to Dr. Ang to answer the pap smear question screening. Yeah.
Sorry, can you repeat the question again?
Okay, so as we continue to do pap smear, when do we stop doing it, basically?
So we start from 25 years old all the way to 69 based on the Health Promotion Board recommendations. But of course, women after 70, if they want to do, they can also continue doing their pap smears. But the guidelines is from 25 to 69.
Okay. Another question is about vaccine. Just now we talked about vaccination is a very effective way of preventing women's cancer. And I've already received my HPV vaccine, Gardasil, over 15 years ago. Oh, actually, that's also me. Should I get a booster shot?
Okay, so I wanted to just also highlight that, yes, in the past, we used to have 3 different vaccines that were available. But I think in Singapore right now, we only have the Cervarix as well as Gardasil 9 that are available. Now, a lot of my patients also ask me, I've had one vaccine, do I need to take the next one? Do I need to go for a booster? Well, studies have shown that the protection actually lasts very long, more than 10, 12 years. There's no current guidelines that you need to go for a booster. Some patients ask if I had one that is bivalent, can I go for the one to top up? Well, there are also no guidelines to say that you need to go for the additional vaccines in terms of the viruses to cover additionally. But there's no safety issues. Women that go for the Gardasil 9 after the Cervix, majority of them will still develop new antibodies against the additional viruses, and there's also additional protection against warts for the Gardasil 9. It's not compulsory to top up. Some patients want to do it, but there's actually no official guideline to say you must go for any top-up boosters or new vaccines.
Thank you, Dr. Ang. Me and my friends actually did the same 15 years ago, and we're also wondering the same. So your answer really clarified some of our questions. So a question for Dr. Zhang about genetic testing. How do you book a genetic testing and how much does it cost?
Okay, I've been answering quite a few questions online because I see many people asking about should I go for testing because I have a strong family history of cancer. So usually genetic testing, we advise to be tested in individual who already have been diagnosed with cancer. That means we do a genetic testing in somebody with cancer first. We usually do not recommend testing in somebody without cancer purely because they have a strong family history, unless those with cancer has all passed away and we are not able to test the individual with cancer, then yes, you can ask for testing. And the referral process is usually go through the polyclinic, ask the poly to refer to NCC, Cancer Genetic Service. Yeah, and from there, once the referral is made, appointment given, we will see you at our Cancer Genetic Service, and then we can counsel you accordingly. Yeah. And for individuals who already have cancer, they can always ask their oncologist to refer them to the NCC Cancer Genetic Service. Yeah.
And how does the cost look like?
Okay, touchy question. So, I mean, there's always the counseling service fee. In terms of genetic testing, it depends on what test we recommend for you. And of course, needless to say, it also depends on the class status. Generally, it can range from between 500 to about 1,200. Yeah. This is a rough estimate. The good thing about the genetic testing cost is that it has come down by a lot over the years. So I remember when we first started just several years ago, it cost a few $1,000s, and you can appreciate how much it's come down. But on the other hand, genetic testing is not covered by MediSave or MediShield, so usually it's out of pocket. Yeah. But anyway, you can always see us first, and then we can counsel you accordingly.
Thank you, Dr. Zhang.
No problem.
And for Amaliah, did your lifestyle or mindset change after your cancer diagnosis?
After my cancer diagnosis, yes, it changed. It didn't change so much. I still go for my regular checks. I still take care of my health. I still talk to people, go for early checks. Everything go back to normal, and I'm just hoping that it will stay this way.
And further on your experience, where did you actually did your screening?
I actually did it at Bishan Center. Yeah, it was actually I didn't need to pay anything. Yeah. So it was just a normal routine check.
Oh, so you went to the Bishan Center of Singapore Cancer Society.
Yes. But it was just a random. I didn't even think I had cancer. It was just a normal check. Yeah.
Yeah. So it's a really great reminder that we have cancer screening services at SCS as well.
Yeah.
Yep. And there's another question for the doctors. What is the aftercare needed to prevent endometrial cancer recurrence?
So I think it's quite difficult to answer this question without knowing the details of the case. I would say that if you've had endometrial cancer and you've had treatment, it's important to actually continue to go for your surveillance clinic sessions with the doctor to actually look and screen for any relapse or recurrences. But the ways to keep yourself safe and cancer-free, I would say basically lifestyle. So we know that obesity and things can actually increase the chance of endometrial cancer. So keeping a healthy body weight and things even like not smoking can actually reduce the risk of other types of cancers as well. Those are ways that I would encourage my patients to do. So don't smoke, keep a healthy weight, diet and exercise, and attend your regular follow-up sessions. And not to forget, I mean, some patients unfortunately can have more than one cancer as well. So not to neglect other things. For example, go for your mammograms for breast cancer, go for other screenings, for example, your FIT tests or colonoscopy for colorectal as well.
Thank you. And there's also a question about CA125, which was discussed. It's not a very effective indicator for cancer, especially in early stage. And what are the different tumor markers that we were referring in the slides? I think this question is
for me, I think I saw that question over there.
Yes.
So I think what we need to understand is that when we talk about screening, like what Dr. Zhang also mentioned, is that screening for patients without any symptoms or any cancer, right? So we're actually trying to pick up, they don't have any symptoms. So we're trying to pick up from the population who are at higher risk. So in that setting, for example, if you had no symptoms, CA125 is not very effective because of what we've mentioned before. But for example, if you had symptoms, like you had bloatedness, you had pain, or when I scan and I see there is a cyst, then I would do the tumor marker to give me an understanding and to help with the diagnosis of ovarian cancer. The type of tumor markers that we use for ovarian cancer for patients that have a suspicious cyst or they have suspicious symptoms, we basically do either CA125, which is more specific for ovary, but sometimes we also add on a CA, which usually they talk about it more for colorectal cancer, but it can also be raised in ovarian cancer. And also sometimes CA19-9, which is more for things like pancreas, but can also be raised in ovaries, yes. And we did talk about the different types of cancer from the ovaries. There are other type of tumor markers, including things like alpha-fetoprotein, beta-HCG, lactic dehydrogenase that might be higher in things like germ cell tumors. I hope that answers the question. So it's differentiating between screening versus when it comes to evaluation of a suspicious cyst.
Thank you so much. And we've come to the end of the Q&A session. If I'm just to recap what we've discussed in the Q&A, if you're in doubt, please go see a doctor, and early detection saves lives. If you have any question related to a genetic testing related to cancer as well, please also refer back to your GP, your polyclinic, or your oncologist if you have any questions. So we have now come to the end of our session. We would like to thank our speakers, Dr. Ang and Dr. Zhang, for sharing their expertise on women's gynecological cancer. We would also like to thank Amaliah for sharing her personal stories. Once again, we would like to thank our sponsors, AstraZeneca, Roche, and our partner, National Cancer Center Singapore, Singapore General Hospital, and KK Women's and Children's Hospital for their support. And lastly, we would like to thank all of you on the line for your participation in this webinar. Before you leave, please help us complete the feedback form by scanning the QR code on the screen. And for more information on SCS Cancer Screening Initiative, just now also Amaliah has mentioned, and other programs, please visit our website at www.singaporecancersociety.org.sg or call 1800-727-3333. Early detection saves lives. Do get screened if you're eligible. And thank you. Have a great weekend.